How to do cataract surgery in a patient with a corneal dystrophy. Hi, Mohammed Al-Mala here. This is a patient with lattice corneal dystrophy. And as you can tell, you can see these marks right here throughout the cornea, and mainly in the right part of the view, as well as centrally and a little bit inferiorly as well. This patient has lattice corneal dystrophy, which can, of course, affect the vision, and it can also affect your view during cataract surgery. Thankfully, in this patient, the condition was not severe and still allowed me to perform the cataract surgery really without much of an issue. So, important here when you have corneal dystrophy is to discuss with the patient and give them realistic expectations of how the vision is going to end up being. This patient has relatively mild disease. She has a cataract. She was complaining about her vision. And so we opted to proceed with cataract surgery in this patient with the understanding that vision may still be limited because of her lattice corneal dystrophy. I had one of my cornea colleagues see her in consultation, so she fully understood her condition prior to surgery. We're completing here the capsulorhexis, a continuous curvilinear capsulorhexis. We started out with a cystotome. We raised the flap with one continuous motion. Things are going well in this patient's surgery. We'll go ahead and do a cortical cleaving hydrodissection next. We'll use BSS on a flat cannula, and we'll go ahead and raise the capsular edge. And you can see there's some separation there, mechanical separation between the capsule and the lens. And once we're sure we're in the right plane, we'll go ahead and inject. We'll do one continuous fluid wave, and that is it. We'll come in next with our phaco probe, and we will do phaco chop in order to remove this nucleus. So, in essence, for this case, for this patient with lattice corneal dystrophy, the surgery is really not any different from what I would do before. Although the view does look quite good here with the microscope, there was some difficulty visualizing the details intraoperatively, but thankfully things have gone well with this case. And the patient has also done well. So we've got a decent crack here, good rotation. We've rotated, we have one heminucleus, and we're going to split this heminucleus into two quadrants. Using an Nagahara chopper to do a horizontal chop maneuver. And then we rotate, good rotation here, and then we have one heminucleus left, which we'll also attempt to crack into two. Very nice. We've got a good chop there. And now we have four quadrants. And we can use our phaco probe now. Same mode. I don't change mode. I'm always in quadrant removal mode. And if I'm not getting good lift or good purchase, I'll go ahead and use my second instrument to extract that quadrant into the anterior chamber. So nucleus a little bit on the denser side here, but nonetheless, we've got that first quadrant out. And we are making progress. Second quadrant, as you can see, use my chopper to position that quadrant, keeping the phaco probe in the center as much as we possibly can. So use my second instrument here. I'm going to rotate two quadrants left, one larger than the other. I try to leave the larger quadrant for last, if possible. If not, then we'll take that out. So here we go, one small quadrant removed, and then we'll tackle this larger quadrant here at the very end. You'll notice that I'm going to use my second instrument here to protect the posterior capsule. I'll keep that between my phaco probe and the posterior capsule in order to decrease the likelihood of posterior capsular rupture. So making progress, taking our time. We're removing the last quadrant here, the last piece of the nucleus. And things are going well for this patient. I just did a mini chop there. I chopped the piece. It wasn't tumbling, so I used my second instrument to chop that quadrant into smaller pieces. Just anything to keep things moving along here. Very nice. Making good progress. Not much cortex there. Good. Very good. And that cortex comes out nicely just with the phaco probe there. Because of the cortical cleaving hydrodissection, that cortex is not densely attached. It's hard to tell in this view. It looks like the posterior capsule has all sorts of things on it, but that's actually the lattice dystrophy from the cornea. That's what's obscuring our view here of the posterior capsule. Nonetheless, I'm going to go in with my Terry squeegee, and yes, we do have some strands there attached to the posterior capsule. The Terry squeegee very effectively cleans off the central posterior capsule, removes any cortical fragments off the posterior capsule centrally. And now we'll go in with Provisc. I will inject to the left and to the right of the wound, and that way if there's any nuclear pieces or cortical pieces hiding in the anterior chamber angle, we can get those out and remove those when we do IA. Provisc to fill the capsular bag in the anterior chamber, and now we'll inject our intraocular lens into the capsular bag. Nice delivery. The IOL will slowly unfold. I'll go ahead and go directly with my IA handpiece and use that to position the intraocular lens. Irrigation is off. I don't turn irrigation on here until we see the haptics are no longer stuck to the optic and they're starting to unfold. Irrigation just turned on. Aspiration, we're using a high aspiration setting to remove the viscoelastic. There's some cortical fragments there. We're going to get those as well. And once we have removed most of the viscoelastic, we'll go to a cortex removal mode, which has a slower rise in terms of the more control over the aspiration rate and vacuum here. And we'll go behind the intraocular lens, remove any viscoelastic maybe behind the intraocular lens. And all that material you see there on the right of the screen, that's all in the cornea. Very good. Good capsular overlap of the optic here. We'll hydrate our wounds, and that looks really very nice. This patient went on to have a great outcome and did very well. Thank you for your attention. When you have corneal dystrophy, be careful. Your view during surgery may not be good, and be prepared for that during surgery. If you need to stay in the anterior capsule, you can. You can stay in it with blue dye if you really have a poor view, and then use your second instrument to protect the posterior capsule. Thank you very much for your attention. Have you done surgery in a patient with lattice dystrophy or corneal dystrophy in general? What techniques do you use? Please comment below. Thank you. Thank you for your attention, and I hope you learned something from this case.